Hello, everybody. We will introduce our speaker, Dr. Cienfuegos, in a few minutes, but if any of you want to introduce yourselves, that would be fantastic.
Hello, this is Pierre Gobin from Serenity Medical.
Hi, Pierre. Pierre, we may ask you if a very specific IIH question comes up, we might ask you to jump in.
Sure.
Okay. Would anyone else like to introduce yourselves? We don't know, like, for example, someone's just called iPhone and someone's just called MN. So if you'd like to tell us who you are, that's great. If not, don't worry about it.
Hi, my name's Shirey, and I'm recently diagnosed with IIH.
Okay, well, thank you for joining us, and we hope we can get you some good information. Where are you? Where in the world are you, Shirey?
I'm in BC, Canada.
Hello, this is
Oh, we lost you.
This is Dr. Niazi. Full name is Mohammed Niazi. I'm a neuro-interventionist in Pennsylvania.
Oh, nice. Okay. Would anyone else like to introduce themselves? We can. Otherwise, I'm gonna introduce our speaker, Dr. Cienfuegos. All right. Well, at the end, people will have a chance again to. Introduce themselves if they have questions. So, welcome all of you. We're really happy to have you. And a big welcome to Dr. Cienfuegos. She's a professor of nutrition at the University of Illinois, Chicago. She is an expert in the field of obesity research. Her Ph.D. in human nutrition and 7 years of research on obesity management have resulted in more than 30 publications in prestigious journals. She has presented her work at national and international scientific conferences, trained professionals worldwide, and actively contributed to 2 R01 projects investigating the health benefits of fasting. In addition, Dr. Cienfuegos has practical expertise in designing and managing clinical trials funded by R01 grants and leading research teams in recruitment, counseling, and data analysis. Her extensive experience in counseling and researching obesity has provided her with valuable insights into the complexities of obesity and, of course, the big topic today, weight stigma. There is a chat, like on all Zooms, there is a chat. So our Q&A is open during the meeting, so please enter your questions. Also, feel free to just introduce yourselves over chat. If you're a physician, what kind of specialty, like Dr. Niazi said. If you are a patient, maybe tell us a little bit about your situation. And feel free to connect with each other. And let's get started. Let's introduce Dr. Sofia Cienfuegos. Thank you.
Thank you so much for that introduction. I'm going to share my screen now. Okay, can everybody see this? Yes? Okay. So today I'm going to talk about a slightly different topic than the one that probably you're all used to hearing in this series. So today I'm going to talk about the impact of weight stigma on patients with obesity and IIH, specifically in the healthcare setting. Okay, so I want to start with a brief testimony. It's really difficult to find testimonies about weight stigma because usually people are very ashamed of admitting that they've experienced such encounters in the healthcare department, but usually people that are relatives to people that have experienced this usually share their experiences. So this is one that said, 5 months after I was born, my mother developed abdominal pain. She had a doctor who said, don't worry, it's probably your excess weight causing the pain. Just try to lose some weight and the pain will resolve. I was about 3 when she was diagnosed with stage 3 ovarian cancer. She pushed through as much as she could to watch me grow, but unfortunately, she passed away when I was 10. Quite literally, her doctor was the death of her. He refused to do anything about except say, your weight is causing the pain. So even though this story sounds pretty horrible for a lot of you, this is way more common than we want to see. So a lot of times people with obesity face situations like this where their symptoms are overlooked. And then after a few years or few months, their symptoms get worse. And then they usually debut with a way more advanced condition. So like Barack said, I'm not going to introduce myself again, but I just want to say, why am I talking about this today? Even though I am not an expert in IIH, I want to be very clear with that. I'm not an expert in IIH. I am an expert in obesity. So I've been studying obesity for like 10 years. Most of my professional life, I've been dedicated to obesity research. I counsel participants with obesity and I do research in people with obesity. So I've been dealing with people with obesity my entire adult life, and I've witnessed the complexities of obesity and weight stigma firsthand. So from my participants, I am a person of normal weight. I don't have personal experiences with weight stigma, so that's important to say. However, I consider myself an ally due to my everyday work in this specific population. So a little bit of an introduction about IIH and body weight and why am I talking about this today? So IIH, as probably all of you know, even better than me, it's a condition of an unknown etiology that primarily affects reproductive age women. It causes increased intracranial pressure, headaches, and vision problems. But I am talking about this today precisely because over 75% of patients with IIH have obesity or overweight, specifically obesity. So obesity is very prevalent among people with IIH. A higher body mass index or a higher BMI, and also weight gain of around 6% of body weight gain increases the risk of IIH and also the risk of complications related to IIH. Unfortunately, the exact mechanism linking obesity to IIH is still pretty much unknown. Unfortunately, there's some hypotheses out there, but there's nothing very clear yet. And weight loss is an effective treatment for IIH. However, I think it's really important to mention here that nowadays in the realm of weight loss, we don't use weight loss as we used to use it years ago, where we try to make people with obesity or overweight go back to their normal BMI. We are not trying to make people with obesity go back to a normal BMI. We're just trying to produce some weight loss that can be effective for treatment. Usually that weight loss ranges between 5 to 10 to 15%. So we don't need to make people lose a ton of weight to go back to their normal BMI. With just around 10% weight loss, so 10% of their initial body weight, we still can see effective and improvements in IIH and all other conditions that are linked to obesity as well. We also see this. Why? So why we usually use this 5 to 10% is because we already know that making someone go back to their normal BMI is not feasible, it's virtually impossible because of the complexity of obesity. So usually a 5 to 10 to 15% body weight is way more feasible and still produces pretty good results. So if we want to understand what weight stigma is and why weight stigma happens, first of all, we need to understand what obesity is. A lot of us work with obesity. A lot of us sort of think that we know what obesity is, but obesity is way more complex than we usually think of. So what's the official definition of obesity according to the World Health Organization? So obesity is defined as an abnormal or excessive fat accumulation that presents a risk to health. A crude population measure, so a very crude population measure, is using the BMI, so the body mass index. And this is basically just dividing a person's weight by the square of their height. If that number is above 30, then that person is usually considered obese. Do I think that the BMI is a good measurement for deciding who's obese or not? Not really. I don't really like the BMI. However, it's what we have so far. Unfortunately, we don't have any other measurements that are as successful as the BMI, but still the BMI has many errors, but it goes beyond the scope of this presentation. So I wanted to show this graph because I think it illustrates really well what's happening with obesity in the last few years. So this is the prevalence of overweight, obesity, and severe obesity in adult US people, so between 20 to 74 years. So it's really interesting to see how, like, around 1980s, the obesity rates have been increasing pretty dramatically. They've been increasing and increasing and increasing, and it's been really difficult to find something that will at least flatten this curve. So there's been multiple public health initiatives, millions of dollars dedicated to obesity research to try to find a way of ameliorating these very, very high rates of obesity. And unfortunately, there's been absolutely nothing that has been able to prevent or treat obesity effectively. We have different strategies, from lifestyle strategies to medications to surgeries. And despite all of those efforts, we have not been able to make this curve flatten or decrease. Obesity is an extremely complex multifactorial disease. I'm going to explain that later, and that is why it's so difficult to treat. So the US obesity prevalence nowadays, there's not a lot of official data for today, but the last that we have is that the US obesity prevalence is around 42%. So if you think about that, almost half of the US adults, almost half, it's 42%, are in the obesity category, and that is alarming. So there's a lot of debate in the general population whether obesity is a lifestyle choice or a multifactorial disease. So this is where most of the weight stigma comes from, because the majority, I'm afraid to say that the majority of the population thinks that obesity is mainly a lifestyle choice. That means that usually people with obesity are lazy. They don't want to exercise. They just want to be at home watching TV, eating pizza, and they don't have any willpower. And they're just basically, they don't care about themselves, and they just watch TV and eat all day. So a lot of people sort of have this idea that obesity is just a lack of willpower and a lifestyle choice. Some other people, or another group of the population, mostly people that are related to obesity research, sort of believe or understand or agree that obesity is a multifactorial disease, independent of their lifestyle, that people with obesity can engage in healthy lifestyles, can engage in physical activity, have healthy eating patterns, but still be in the obesity category according to the BMI. Why? Because there's many factors besides the lifestyle choice or the calories in and calories out that will affect this condition. So I just want to explain a little bit about energy balance. Probably you've all heard about energy balance and you all kind of understand energy balance, but I just want to explain it very briefly, just in case some of you are a little bit confused with this. So energy balance, also known as calories in and calories out, is the most accepted way of explaining how our bodies maintain our weight. This is how we maintain our body weight. So energy balance is the relationship between the calories or the energy that we consume through food and drinks and the amount of calories that we expend through physical activity and our bodily processes. So the energy that comes in to the energy that comes out. So calories in is the energy from foods and drinks, and the calories out is the energy expenditure through bodily functions, physical activity, thermic effect of foods, among others. So if we consume the same amount of calories that we burn, we will maintain our weight. If we consume more calories than the amount of calories that we burn, we will gain weight because those calories are going to stay in our bodies. It will stay in our fat deposits, making us accumulate more fat and gain more weight. And if we eat less calories than the amount of calories that we expend or that we burn, we will likely lose weight because we're going to start using our own body reserves. So based on this, the energy balance, that most people understand this, they say obesity is very simple, right? If you just eat less and exercise more, you will lose weight. It's not that complicated. Just eat less and exercise more. Why is people with obesity so difficult to change? You just need to eat less and exercise more, and that's the only strategy to eliminate obesity from the world, basically. And even though that might be true, if someone eats less calories and burns more calories, they will lose weight. The problem is that the amount of variables that will affect the calories in and the amount of variables that will affect those calories out is huge. There's many, 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 many variables that will affect these calories in and calories out. And that's the part that people tend to forget about. Calories in and calories out is real, but the variables that affect those calories in and calories out is very, very extensive, very complex, many factors. If I wanted to explain all of them, I would be here for weeks, because it's a very, very complex interplay between physiological factors, environmental factors. Just to illustrate the complexity of this, I want to show you this graph. So this is the obesity system map. It's just illustrating the amount of factors that will affect the energy balance that I explained on that last slide. When you understand how complex obesity is, ranging from the appetite control, the resting metabolic rate, the level of satiety, the food exposure, the social media availability, the cost of physical exercise. There's so many variables in your environment, in your own bodies, related to your genes, related to your microbiome, related to your zip code, related to your upbringing, related to who your parents are. There's so many things that will influence obesity. When people start understanding the complexity of obesity, it makes a little bit more sense. Why is it so difficult to treat obesity and why obesity rates have been skyrocketing? Also, it makes you understand why for some people it's so difficult to change, because it's not just eat less and exercise more. There's many variables affecting those two things. So it's not as simple. This doesn't mean that there's no room for change. Of course, there's room for change. And there's a lot of obesity specialists and dietitians that work really hard to try to help people sort of control or manage different aspects to try to treat obesity, but it's still very, very difficult. So when you understand the complexity of obesity, the stigma starts to fade away a little bit. So that's why it's very, very important to understand the complexity of obesity. So now that we understood a little bit about the complexity of obesity and what obesity is, we can start to understand what weight stigma is. So the definition, or the official definition of weight stigma, is the discriminatory acts and ideologies targeted towards individuals because of their weight and size. So it's the discrimination or treating differently or unfairly someone because of their body size, and also all of the preconceptions and stereotypes that people have towards people with overweight or obesity. Stereotypes such as people are lazy, they're overeating, they have poor health. A stereotype that's very common in the healthcare setting is people with overweight, probably all of their health problems are because of their overweight. Probably they are not going to adhere to whatever we tell them to do, to the treatment plan, and many others. So weight stigma manifests in various domains of life, such as healthcare, the workplace, interpersonal relationships, among others. But in this talk, we're going to focus on weight stigma in the healthcare setting. Something that's really dangerous with weight stigma is when people sort of internalize this weight stigma, meaning when people start to believe these preconceptions that people have about them, they start believing those things about themselves. They start thinking that they are actually lazy, that they're actually unhealthy, that it's all of their fault, that that's what they are. They sort of identify with those ideas. And it's very dangerous because this leads to many problems related to mental health. And also this deterministic mindset of this is who I am, or this is what I am, makes it very difficult to change, to engage these patients in treatment plans or in changing these behaviors, because they already sort of identify with these stereotypes and these preconceptions. Another way of sort of where weight stigma can happen or show in the healthcare setting is through medical equipment. A lot of people don't realize this or don't think about this, but medical equipments and facilities are often not designed to accommodate larger patients. So if you think about it, just to give an example, so in our lab, we usually treat people with obesity. Most of our participants are people with obesity. So we know that we need to have larger sitting or larger chairs in our waiting room. We know that we need larger blood pressure cuffs in our clinics because most of our patients have larger arms. We know that we need scales that go higher than 300 pounds because we know that a lot of our patients weigh more than that. We need to have different equipment that is sort of accommodating to larger patients because that is our population. A lot of healthcare settings do not have facilities or medical equipment that is designed for larger patients. And most, or I wouldn't say most, but a lot of clinics do not have blood pressure cuffs that can accommodate larger arms or scales that go higher than 300 pounds. Some people would say, okay, why should I invest or change my infrastructure for those few larger patients that I have? I think that's a valid point. However, if we think that about the slide that I showed you earlier, that almost half of the US adult population is in the obesity category, then you start realizing that's probably not a few patients and probably almost half of your patients. If you also work on a specific condition where most of your patients are overweight or obese, then probably even more of your patients will need those specific facilities or medical equipment. And this is not validating obesity. Some people would say, okay, so if I sort of change all of my environment to accept or to accommodate people of larger sizes, this is like sort of accepting obesity. Not really. This is just acknowledging the reality of this country, and it's just making your practice more welcoming and more accommodating for people of larger sizes and making them more likely to come back and to adhere to the treatment. And that's something that we'll discuss in a few slides. So weight stigma in an everyday environment, weight stigma that people face in the grocery store is hurtful for them. Of course, it's terrible. But weight stigma in the medical setting can have life or death consequences. The prevalence and the impact of weight stigma, so around 53% of women with obesity report hearing inappropriate comments about their weight from healthcare professionals. And this is hurtful to read, that almost half of women with obesity hear negative comments about their weight from healthcare professionals. It is the profession that we should be neutral, that we should be accepting, that we should be compassionate, and still half of them are hearing these comments from healthcare professionals. 79% of people with excess weight or obesity report eating more to cope with weight discrimination. And this is really important because a lot of healthcare professionals still believe in this idea of like the shock therapy. If I tell them that they're overweight, if I tell them that they're obese, if I tell them that they need to change, if I tell them that they're wrong, that's probably going to help them because they're going to realize and they're probably going to make a bigger change. No, that is not the case. People with obesity know that they have obesity. They've been told that their entire lives. There's nothing new about this. And research shows that when someone with obesity feels stigmatized or discriminated, that only leads to eat more and to gain more weight and to make the cycle worse. 52% of women say that weight has been a barrier to appropriate healthcare, delaying or avoiding preventative care. And this is one of the most dangerous things. And we'll also explain a little bit further in a few slides. And then 40% of healthcare professionals admit having negative reactions to patients with obesity. So 40% of healthcare professionals, negative reactions. Again, it's the profession where we should be compassionate and we should be accepting of everybody, regardless of their religion, size, race, everything. And this is still happening. So of course, there's a huge emotional toll of weight stigma. Patients experience increased risk of depression and anxiety, feelings of shame, low self-esteem, body dissatisfaction, impact on body image and identity formation, and social isolation. All of these problems or emotional reactions will affect their mental health, and a poor mental health makes treatment or adherence to treatment way less likely. So now let's talk a little bit about weight stigma and IIH. So like I mentioned in the beginning, IIH and weight stigma, it's relevant to talk about these two topics together because in the context of IIH, because of the high prevalence of obesity among patients with high IIH. Weight stigma can impact the diagnosis of patients with IIH, and it also can lead to inadequate treatment and disease progression. So I'm going to try to illustrate it from this diagram. So let's say that there's a patient with obesity, female patient with obesity and IIH, undiagnosed IIH. So this patient has been through multiple healthcare professionals. Most of them have not been great encounters. Most of them have focused only in her weight. So this patient consults for severe debilitating headaches. She decides to consult with a healthcare professional, with a primary care physician. And this primary care physician, let's say that this physician has been seeing multiple patients that day. So this is his last patient of the day. And then whenever he gets to the consult, she starts telling him all of her symptoms. I've been experiencing these really terrible headaches. They're super debilitating. I have some vision problems. And this physician, while looking at her, his mind and his brain probably goes to, okay, this is sort of an easy case. I know probably what's going on here, and I know it's probably the weight. We know that excess weight is going to cause multiple things that could manifest in debilitating headaches, and all of these things will probably get resolved with weight loss. So then this physician will say to this patient, okay, I understand that this has been difficult for you, but I know that a lot of these things can be affected by your weight. So let's try to do this. I'm going to give you a meal plan, a 1,200 calorie meal plan. So you can do this 1,200 calorie meal plan for a month. You can try to exercise a little bit more so you lose some weight. And then we can see each other in one more month. If the symptoms persist, maybe we can do more extensive testing. But if the symptoms change or improve, then it was probably just the weight. So even though it's not ill intention, it wasn't something mean, the physician just wanted to help. This was a weight-centric focus because the physician only recommended weight loss strategies as a treatment approach. What happens with this is that this patient is going to have a lot of psychological impact because she will realize that she was not being seen. The only thing that physician saw was her weight. She wasn't seen. The only thing that was seen was her weight. And that's something that she probably has experienced her whole life. So this just reinforced her idea that going to the doctor is just being shamed or fat shamed, given a 1,200 calorie diet that she has tried multiple times. She has tried multiple diets and multiple exercises, and she knows that even though she might lose a few pounds, she usually regains them. So what's going to happen with this patient? She's probably going to toss that 1,200 calorie meal plan. And the problem with all of this is the disengagement from healthcare. This patient is probably not going to go back in a month. So this patient is not only not going to do the weight loss strategy that was recommended, it is also not going to go back to that physician. So this is the real problem with weight stigma, is that patients feel stigmatized, feel discriminated, feel unseen, and they don't want to put themselves through that again. So if there is a disengagement from healthcare, then there's probably a disease progression. How to prevent weight stigma, some strategies on how to prevent weight stigma for healthcare professionals. So something that might seem very obvious is to treat every patient with empathy, respect, and dignity. Even though this seems, again, very obvious, it is crucial to remember that we are healthcare providers and every patient deserves to be treated with empathy, respect, and dignity. Create a safe space for patients to discuss their health concerns and feelings openly. And something that's very important is that before discussing weight loss strategies, perform all the appropriate medical exams and laboratory tests. I'm not saying here that we should always adopt a weight neutral approach. I know that weight loss is a very important strategy for treating IIH. However, it's really important for this patient to feel seen, to feel examined, to feel that there's more things that that were analyzed and not just the weight, that the physician wasn't just focusing on her weight or his weight. So perform all of the appropriate medical exams and laboratory tests. Then take a comprehensive approach to healthcare. So don't just recommend weight loss. Try to find other alternatives. Try, if medication is necessary, recommend medication. If another approach is necessary, recommend another approach. Try to give multiple options and try to ask the patient if the patient is comfortable with the options that you're giving. Not just focus on weight. Offer resources such as educational materials, support groups, and for me, the most important thing is referrals. So if after your examination, you realize that this patient will benefit from weight loss therapy or weight loss strategies, try to refer the patient to a weight loss specialist, to an obesity specialist, to a dietitian, but don't try to just say, eat 1,200 calories and exercise more, or don't try to do it yourself. Try to refer to a specialist. Also, ensure that all healthcare settings are inclusive and accommodating. Yeah, I know that this is difficult. It's not something that's going to happen from one day to the next day. Of course, this requires a process, but if you're able to adapt some of your medical equipment and some of your healthcare setting to a more weight inclusive one, this is going to make patients feel way more seen and way more taken into consideration in your practice. And also, it's really difficult to recommend weight loss or to recommend decreasing blood pressure if you don't know what their initial weight was or their blood pressure was. Engage in self-reflection to recognize personal biases and actively work to challenge them and overcome them. So even though this is difficult and we all have in more or less degree some level of weight stigma in our brains because we've all grown up with this. So from the movies that we were watching to the cartoons, there was always the obese character that was the one that was overeating, the one that wasn't exercising, the one that was sad, the one that was alone. So all of these ideas have been engraved in our brains throughout our lives, and it's really difficult to unlearn them. But this is something that we specifically as healthcare professionals, we need to try to sort of dissolve all of these preconceptions and all of these stereotypes from our brains to give our patients the best care possible. So raising awareness about this and advocacy is extremely important. It's crucial for promoting equality and fairness in healthcare settings. It helps to challenge societal misconceptions and stereotypes associated with weight and body size. It also improves the access to appropriate diagnosis. So this is the most important thing, improving the access to appropriate diagnosis and treatment specifically for people with IIH, regardless of their weight, and empower individuals with IIH or other obesity-related conditions to speak out against weight bias and advocate for their healthcare needs. So addressing weight stigma and weight bias creates a supportive environment that fosters a positive patient-provider relationship and improves overall IIH patient outcomes. So thank you so much for listening to my presentation. I don't know if it was longer than it was supposed to, but if you have any questions or concerns or comments, I'm happy to address them now.
We have one question. We have one comment from the audience and one question, and then I'm sure other people will want to come in. Sue Borneman, would you like to read your comment, so in case people weren't looking in the chat, or would you feel comfortable doing that?
Sure. So I'm a nurse practitioner, and I am also a patient with IIH. In one of my support groups online, it was very interesting. A woman of normal weight contacted a neuro-ophthalmologist because she was symptomatic of IIH and seeking evaluation to assess if she had papilledema. When she was questioned about her history, the provider told her she couldn't possibly have IIH because that is a, quote, fat woman's disease. And she presented that in the group, and it's interesting to be present in this particular webinar, because in the group that I'm in, weight stigma is significant. The number of individuals, whether they are male or female, yes, we know the statistic is high, 75% with IIH. But the persons in the group are hurting by their healthcare providers in the way that they are being treated. And I'm so appreciative for this webinar. And I really hope that the word gets out that we really need to treat people with more dignity and respect with regards to this, and not just persons with IIH, but everybody with obesity.
True. It's some people sort of believe that this is something that's not happening anymore and that things are changing and people are way more inclusive now. But it's heartbreaking to know that things are not changing that much, specifically in the healthcare setting. It's awful. It's still happening. And it's just, we need to try to raise more awareness, try to, as healthcare professionals, try to talk about this more and explain that obesity is a very complex disease. Also, not obesity is also a disease. Some people, some medical professionals see someone of a larger body size and immediately assumes that this is an obese patient with a lot of metabolic conditions and probably very unhealthy. But actually, we know that there's such thing as healthy obesity and metabolically healthy obesity. So just assuming how somebody is just from how they look is very, very damaging, specifically in the healthcare setting. So yes, it's something that we definitely need some change.
Thank you, Sofia, and thank you, Sue. We have a question from Pierre Gobin in New York. His question is, I have a question about who should treat obesity.
Yes. So usually who treats obesity is obesity specialists. So there's a medical specialty of obesity medicine. So obesity specialists, also endocrinologists and dietitians. So from my point of view, those are the three sort of referrals for people with obesity. Nowadays, there's more options. So nowadays we have this new class of medications, GLP-1 analogs. We still don't know how effective they will be long-term, but they're very promising. So nowadays, a lot of people with obesity are being treated with these medications. I'm completely in favor of that, if the patient agrees, of course. So there's different options, but usually, like I said, obesity specialists, endocrinologists, and dietitians would be the ideal ones for referrals.
Can I speak there, Barak?
Please. You want to put your camera on if you like.
I'm fine. No, so
okay.
I'm going to play the devil advocate here. We have a disease that is involving 40% of the population. You cannot refer those patients to a specialist. I think they should be treated by their PCP. how do you educate the general practitioner to take care of his patients? Maybe only the most extreme obese patients should be referred to an obesity specialist. You cannot refer 40% of a population to a specialist.
I agree. I agree that referring all of the participants to an obesity specialist is a lot. However, it's really difficult for primary care physicians to effectively counsel because in medical school, they are not taught on how to do this. So I think that the first step on trying to address this problem is training medical professionals on how to counsel and how to treat obesity and how to effectively use lifestyle strategies on treating obesity, learning about nutrition, learning about how to address this. But most of primary care physicians just don't know how to treat obesity. So in our lab, we study intermittent fasting. That's my area of research. That's what I research. So intermittent fasting is a strategy that it's very simple to administer. And we study that strategy because we know that not every patient is going to be able to be referred. So we are trying to find like easier strategies for primary care physicians to use. Fasting is one of those, but again, fasting is not for everybody. It's for some participants, it would be a good strategy. So fasting is a very easy strategy to sort of be given by primary care physicians because there's not a lot of different nitty-gritty things that they need to counsel. It's just asking participants to monitor the timing of food. So it's one strategy, but honestly, I think that the best strategy would be increasing the amount of nutrition-related courses in medical school, from my point of view.
Sue's jumping into the question saying family practice does not have time, which is an interesting take as well. Ala El Hanouni has a question. Dr. El Hanouni's patients ask, sorry, I've lost it in the chat. Patients ask me if they should worry about their BMI if it is in the overweight obese category. Do you have any thoughts on that, Sofia? Dr. Cienfuegos.
So I would say it's not just, so when you assess the nutritional status or the nutritional status of someone, it's not just looking at the BMI. You need to look at many other markers, right? So the BMI is just a very imperfect measurement of your nutritional status. You also need to try to measure their body composition. So to see if that weight, is it just fat? Is it muscle? Also try to understand what type of fat. Is it subcutaneous fat? Is it visceral fat? How the weight circumference is relative to their weight. Also do some lab testing to know if their metabolic markers are okay or if they're altered. If it's a patient that engages in physical activity, eats relatively healthy, has a higher BMI, but most of their fat is subcutaneous fat and all of their labs are fine, then I wouldn't worry that much for weight loss. This is in the context of a patient that does not have IIH. This is a like quote unquote healthy patient. Of course, it would be ideal for that patient to not be in the obesity category, but if that patient does not want to engage in weight loss and their all of their other markers are okay, there is such a thing as a healthy or metabolically healthy obesity. But if that patient wants to lose weight, of course, there's some strategies that could be discussed to decrease that weight, but it's not something to be completely worried about. That would be my opinion.
We have another comment from Dr. Goban, from Pierre, and I think this is a very interesting comment because he says, I have my own prejudice. And you said, Dr. Cienfuegos, earlier that it's important for all of us to address our own biases if we're going to try to dissolve them. Now, I will read it. I have my own prejudice. The epidemic of obesity is mostly due to processed food, and we should fight the food industry like we fought the tobacco industry 20 years ago. And I'm curious if you can address that as a fact and as a thought, but also in the context of what we're talking about today.
I think that definitely the food industry has a lot to do, not everything to do, but a lot to do, because there's been some studies trying to assess the effect of ultra-processed foods in health and in weight management and weight regulation. And these studies have seen that eating more ultra-processed foods independent, like if you match the amount of calories, if you eat more ultra-processed foods, you will gain more weight and you will gain more weight more rapidly. The main reason behind that is that the food industry usually needs to sell. And when you need to sell, you need to make products that are tasty. And to make products that are tasty, you need to increase the amount of fats and sugars. And when you increase the amount of fats and sugars, you gain weight more easily, and some other markers in your body gets dysregulated. So definitely the food industry has something to do, but I don't think that it has everything to do. So I think it would be interesting to sort of put some regulations on the food industry, but again, it's difficult on how those regulations are going to work facing the consumer's preferences. For instance, in my country, I'm from Chile. In my country, there was a very big public health effort to put stamps on different processed foods on the amount of sugar and calories and salt and different things like that. So the industry started responding to this sort of initiative. Especially the products that had a lot of sugar, they started replacing the sugar with artificial sweeteners, so they didn't have the stamp of high in sugars. So they replaced all the sugars with artificial sweeteners. But now we know that artificial sweeteners are not that great and are not that safe, specifically for kids. So now we have another problem. So it's usually one problem and then another problem. It's really difficult to find like a really perfect strategy and balance. So that is why everything related to weight and obesity is so difficult, because all the strategies have proven kind of wrong or difficult or dangerous also. So that's my point of view there. I don't know if someone wants to add something.
Well, I want to, so I apologize. I think I've remembered your name correctly, Shirey. You're making a couple questions and comments. I wonder if you'd like to just get on yourself and ask your question about make your comment about the time, how little time physicians often have. So sorry, I have my dog wants to get involved. I don't know if you can hear her barking. I'm going to mute. So Shirey, would you like to come on, or would you like me to read your yeah? See, you're here.
No, I could come on. I just in the last point of what you're talking about with the packaged foods, I agree with that, because I found that high levels of sodium trigger my symptoms really bad. So if I actually pay attention to the level of sodium in everything I eat, especially packaged foods, I basically don't eat packaged foods anymore. Everything has to be very natural. Yeah, my symptoms flare up really bad from that, I've found. Yeah. And my other comment was just that when I do have my doctor's appointments, I do feel like very unheard. I don't feel that she really has the time. She just kind of wants to give me the treatment and get me out. And like, that's medication at the moment. She gave me Diamox. But yeah, I don't feel like there's an open discussion about anything else really. And I don't know what I could say to ask for more of that, I guess, or get more out of her.
Yeah, I think that's something that's very common, specifically in the US. So where I come from, usually doctor's appointments are longer. In the US, I feel like doctor's appointments are like 10 minutes or something. And it's just like a in and out thing, and you just get the medication. That's it. I don't know if there's a way of asking her or maybe telling your thoughts, because it is very kind of dehumanizing in a way when you feel completely unseen and kind of ignored. So I hope that maybe by talking to her, you can find a solution. I don't know if anybody else here knows a strategy on how to deal with that. I don't know.
It's funny, I'm actually in Canada too, so not the US.
Oh.
Yeah.
I don't know.
Yeah.
In Canada, I don't know. Yeah, that's terrible. I'm sorry. Oh, I think you're muted, Barak.
Sorry. This is just an idea as someone who's who's had to go to the doctor a lot, sometimes either going in with a list, but also going in with maybe a friend or family member that you really trust, then you're two people. And it's very easy to forget sometimes, especially if you're stressed. It's very easy to forget all the questions, even if you have a list. So that's one potential thought. I know it's not always easy for everyone to take a friend or family member with. We have another question from Sue Borneman again. What is the most implicated issue correlated to obesity in the United States? Like the biggest biggest culprit.
So there's a lot of research trying to like sort of say what's the biggest contributor to obesity. And again, because obesity is such a multifactorial disease and there's so many factors related to it, it's very difficult to find the single most important one. So I would say that in general, and when you think that the obesity rate started to increase very significantly around the 80s, it has something to do with our way of life, with our lifestyle. So it's not a lifestyle choice, but our modern lifestyles sort of makes us a little bit more likely to gain weight. Why? Because we work a lot. We don't have a lot of time to cook, and we tend to just buy foods that are already made because we don't have a lot of time to cook. So when you combine those two things of not being able to move because you're working all day or busy all day or driving all day, so you're not moving or expending energy, and you are eating out, and that food, as I mentioned a couple minutes ago, is usually food that's made to be palatable and made to be sort of like a business thing, so people want to sell. It's also food that's high in sugars and high in calories and high in fats. That's kind of a perfect storm of like not moving and overeating without realizing that you're overeating. But then when you start gaining a little bit of weight because of that, that's where all of the other factors starts to come in, where your appetite and satiety sort of areas in your brain gets altered, where all of the other things happening in your body starts to get altered as well. And that's when it's really difficult to reverse the situation. And it starts to get worse. That's my take. Again, there's nothing completely clear here. Again, it's like many causes, and we're not completely sure which one is the worst one. This is my sort of idea. Yeah. You're muted again.
All right. So we're going to need to start wrapping up just because we want to be respectful of everyone's time. But one question from Dr. Goban is, do you have a comment on the Michael Pollan quote, eat food, not too much, mostly plants? How does that fit into this larger conversation?
So I would say I have my own biases. I have my own biases as well. For me, that's kind of true. So I eat mostly plants. I am vegetarian, so I do think that eating mostly plants is the way to go. Eating real food is the way to go. But again, I have my own biases. That's what I think is the best, and that's what works for me. But honestly, there's not a lot of research saying what's the best. Some research out there says that mostly plants is very low in protein, and it's not great, and it's not enough satiety. And so there's so much information out there that it's very difficult to have a clear response. But from my opinion, eating low processed foods, moving, drinking water, and eating plants for me is the way to go. But again, it's my own biases here talking again.
Is there any data pointing to any sort of genetic component to obesity? This is a question someone's asking.
There's also debate here. There's also debate. There's some people that say, no, there's zero genetic compound here. It's just lifestyle and like epigenetics and like where you were born and the household you were born. But there's some research that I've seen that there are certain genes linked to obesity, certain links that make you absorb food more efficiently, that makes you sort of store food more efficiently, links leading genes related to insulin. So the general consensus is that there is a genetic component. It's not very significant, but there is a genetic component to obesity. That doesn't mean that if you have those genes, you are 100% destined to be obese. No, but there are some genes that will make you a little bit more likely to have obesity.
Okay. Do we have any further questions that people want to ask quickly before? Oh, well, here we go. We do have another one from Dr. Alanuni. Are you familiar with well, you have mentioned Ozempic, but are you, so you are obviously familiar, but the question is, are you familiar with weight loss medications like Ozempic? If a patient asks about this, when would you recommend these? What kind of questions would you ask to determine if a medication is the way to go?
I do think that these new medications, GLP-1 analogs, are a very good strategy, but only in the context of other strategies not working. I think that we should always try to aim for lifestyle interventions first. Lifestyle interventions first. If that doesn't work, from my point of view and from the data available, I would say that the best medications nowadays for treating obesity are these new GLP-1 analogs, such as Ozempic, such as Mounjaro, such as Wegovy, and all of them. So they're really good. The side effects are pretty minimal compared to other weight loss medications that have very high side effects related to blood pressure and others. They're non-stimulant based. They have pretty interesting, pretty successful results, specifically the new one that's called Mounjaro, tirzepatide, really, really impressive weight loss results, almost similar to bariatric surgery. The only thing that's unknown is how is it going to work long term? These medications are supposed to be taken long term. Most of the studies that we have are following patients for 2 years. We don't know if beyond those 2 years they're going to still be effective. But for now, I would say it's like some of the best obesity treatment that we have out there. But again, I would say first try lifestyle strategies. These medications are expensive. They are not always covered. And that's one of the big drawbacks for these medications, because if you don't have diabetes, most of them are not covered by insurance. So, but I do support them. I do think that they're very impressive from like an obesity weight loss point of view. Yeah. There's still questions. I don't think that they're magic, but I think that they're very impressive.
There's one last question, comment, and then we're going to have to wrap it up. This has been such a wonderful interactive conversation. So Sue Borneman has written, I lost 15% body weight, then developed IIH symptoms. Sue, do you want to elaborate on that? And then maybe both Dr. Cienfuegos and Dr. Goban could potentially give their thoughts.
Oh, sure. Yeah. It was just like from September to November, I had lost this 15% body weight. I was obese at that time, but then I had a sudden slide in symptom development to quite the severity that I am currently off of work now for the last 3 months and not able to return to work because of the severity of the IIH symptoms that I currently have. The weight loss stopped, but it's just so interesting that it's implicated in reducing symptoms, but in talking to a number of different people, I'm not the only person who's experienced weight loss and then subsequently developed symptoms.
So those were your first symptoms. It's not that you
Yes,
have
I was only just diagnosed in February.
well, I would, if Dr. Cienfuegos or Dr. Goban, both of you would potentially like to jump in.
So I am not the expert in IIH here. I think Dr. Gnan would be the best one to respond to this question. I'm really sorry that you're experiencing this.
Thank you.
Yeah.
Yeah, I think it's just one of those things. It's just every body happens to just be different.
Maybe, I don't know, I'm not an expert here, but maybe it could be that your own particular type of IIH is not because of weight. Maybe it's linked to something else, not just weight, and that weight loss made it worse. So maybe it's not just the weight in your case, it could be something else.
And I think that could be it, because I was found to have bilateral transverse sinus stenosis that expanded into the sagittal sinus. So I think it's venous congestion related mostly.
Could be. It could be.
Yeah.
Dr. Goban, would you like to comment?
Yes, of course. I think that you should see a neurosurgeon who is also an endovascular surgeon, because you might be candidate for surgical treatment of IIH. Because if you have lost weight, 15% weight, that's really a lot. Yeah, that's a lot of effort. And usually in IIH, many patients improve after a 50%, after a 15% weight loss. Most patients cannot get to there. So you did that. That's a tremendous effort. And if your symptoms are not improving, and if you have diffuse transverse sinus stenosis, then you might be candidates to surgical treatment. If a transverse sinus stenosis is really localized, then a stent could be a solution. If it's diffuse in many sinuses, then maybe a shunt might be a solution. But medically, I think that we'll not be able to do much more than what you have achieved, you know, with your weight loss.
And it's interesting.
Thank you. Yeah, it's interesting you say that, because I did just get a stent.
You did?
I did. Yeah, I'm 5 days post-op.
Hey.
Oh, you got one. Wow. That's good. You did the right thing then.
Good.
Yeah.
Yes, thank you.
All right. I just, because it's, especially for those people on the East Coast or even further east, it's getting to be late. I think it's time for us to wrap up. Dr. Cienfuegos, do you have a closing comment before I wrap it up?
No, I just wanted to say thank you. I think it was a really interesting discussion. Again, I usually don't talk about these topics that often. I usually present about intermittent fasting mostly. So this was getting a little bit outside of my comfort zone, and I really liked it. So thank you so much for listening. I think we should all kind of be advocates to this topic and try to raise awareness, because even though some of us might think that things are getting better, it's not always the case. So we should definitely try to advocate into weight inclusivity. And thank you so much for listening. And I hope that you guys have a good rest of your day and night for some of you.
Well, thank you so much. I want to just quickly share my screen and just invite you all to do a few things, one of which is to come check out IIH's YouTube channel. We have very soon, Dr. Cienfuegos's video will be up there in its entirety, but also short clips. And we've had quite a few lectures already. And so you can see there's a lot of content here, ranging from the IIH patient journey through diagnosis to very, very specific topics. So this is a great resource. And of course, check out iihhub.com. We're also on Instagram and Twitter. And also, please, I would urge you to check out Dr. Cienfuegos' Instagram. She has a lot of followers and she posts a lot of incredible content. A lot of it is in Spanish. So for the couple Chileans on the call, this will be very comforting to you. She's Sofia 100. And the last thing I want to share is that our next lecture is with Dr. Atos Patsalides, a neuroradiologist and associate professor of radiology at Weill Cornell Medical College in New York. It will be on Thursday, July 13th at, again, 6 p.m. on the East Coast, 3 p.m. on the West Coast. The topic will be announced very soon. So if you're not already on our email list, and I'm sure you are because that's how you got here, we will be announcing the specific IIH topic very soon. So I want to thank you all very much. Thank Dr. Cienfuegos very much, and Dr. Goban as well for your answers, and everyone for your questions and listening. And we hope to see you next time. Thank you so much.
Thank you so much. Bye.